Welcome to the Asthma Care coverage. Welcome to the Asthma Care coverage in 2020. An update from the Asthma Care Guidelines-Based Care Coverage Project. Before we begin, as a reminder, at the bottom of the screen, there are multiple application widgets you can use. All of the boxes are resizable and movable, so feel free to move them around to get the most out of your desktop space. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browser session running in background that could cause issues. For the best audio quality, please make sure your computer speakers or headsets are turned on, and the volume is up so you can hear the presenters. And make sure the media player on your screen is enabled. If you have any technical difficulties during the webcast, please let us know by the Q&A box. If you have any questions during the webcast, you can submit them through the Q&A box as well. This webcast is being recorded and will be available tomorrow and can be accessed using the same link you used to register. And now we'll begin the webcast and turn it over to Ms. Erica Sward, National Assistant Vice President of Advocacy for the American Lung Association.
Thank you very much, and good afternoon, everyone. Welcome to the American Lung Association's webcast on asthma care coverage in 2020. I'm very pleased to have all of you join us today and look forward to introducing our speakers in just one moment. Before we begin, I want to acknowledge that this presentation is made possible by the grant number you see here on the screen, funded by the Centers for Disease Control and Prevention. Its contents are solely the responsibility of the authors at the American Lung Association and do not necessarily represent the official views of the Centers for Disease Control and Prevention or the Department of Health and Human Services. I'm going to just give you a brief overview of the American Lung Association's Asthma Guidelines-Based Care Coverage Project. The Lung Association tracks coverage of and related barriers to the NAEPP guidelines-based asthma care data in every state Medicaid program every year. And the three objectives of the program are to increase understanding of Medicaid coverage and the barriers to accessing guidelines-based asthma care in all 50 states, the District of Columbia, and Puerto Rico, to identify gaps between what is known to be best practice in improving asthma outcomes and what is actually covered by state Medicaid programs, both the fee-for-service and the managed care, and then finally to promote collaboration between diverse stakeholder groups to increase access to guidelines-based care. It is my pleasure this afternoon to be joined by three very distinguished and knowledgeable presenters. First, Pam Collins with the National Center for Environmental Health at the Centers for Disease Control and Prevention. Second, Hannah Green with the American Lung Association, who will talk a little bit about COVID-19 and its implications for asthma care coverage. And then finally, Emma Will, who will walk us through our 2020 asthma care coverage data. We will then have some links to resources and then go through a Q&A. But at any time, you can type your questions into the Q&A box at the bottom of your screen, and that includes any technical questions that you might have. So it's now my pleasure to turn our presentation over to Pam Collins from the CDC. Pam?
Thank you, Erica. Good afternoon, everyone. I'm Pamela Collins, the Deputy Chief of the Asthma and Community Health Branch, and also the subject matter expert working with the ALA's Asthma Guidelines-Based Care Project, along with Paige Welch and Carol Johnson. Through a CDC cooperative agreement in 2015, the American Lung Association began tracking the coverage and related barriers to asthma guidelines-based care for state Medicaid programs. As Erica also talked about earlier, the goals and objectives, the project is also to improve access to guidelines-based care and ultimately improve asthma outcomes by understanding the gaps between what is known to be best practice in improving asthma outcomes and what is actually being covered by payers, including Medicaid, and implemented by providers. Today's webinar will focus on the common formularies in Medicaid programs and Medicaid coverage of device for patients with asthma. Now I will turn it over to Hannah.
Thank you so much, Pam, and thank you all for joining us today. Before we jump into the coverage data that we'll be releasing today and talking about the 2 issue briefs that Pam just previewed that we're also releasing today, I want to take a few moments to talk about COVID-19 and its impact on our entire healthcare system over the past few months, but especially it certainly has impacted the Medicaid program. You know, a lot of data on changes in Medicaid enrollment as a result of the COVID-19 pandemic is still coming in. But, you know, one initial analysis done by the Georgetown Center for Children and Families looking at 15 states where Medicaid enrollment information was available over the first 3 months of the pandemic found an increase of 5.8% between February and May. And indications that would, you know, be continuing to pick up as more information came in. So today I wanted to talk a little bit about some of the tools that Medicaid programs have available to them to make policy changes as a result of the COVID-19 pandemic, and provide some examples of how states have used those tools to make changes that impact coverage for patients with asthma and directly impact some of the categories of coverage that we look at and some of the barriers to care that we track through this project, and talk a little bit about how we dealt with those temporary policy changes when we were collecting the data this year. So this slide just outlines a few of the different tools that states have at their disposal to make policy changes related to COVID-19 right now. And some of these may be familiar to those of you who have worked on Medicaid coverage issues for patients with asthma over the past few years. Tools like a state plan amendment are tools that are available to states, you know, year-round, all of the time, regardless of whether or not we're in a pandemic, to make changes to their Medicaid programs. Every state has a state plan on file with the federal government that outlines how they'll administer their asthma program, and states can use the state plan amendment process to make changes to benefits and services that they cover and request to make those changes with the federal government. So an example that we often talk about in the asthma coverage space is that the Missouri Medicaid program worked with the asthma program to submit a state plan amendment that expanded coverage of home visiting services and self-management education for patients with asthma in that state. But SPAs, state plan amendment SPAs, can be used to make changes related to COVID-19. States can also make implement changes under existing authority that they have from their state plan without having to file an additional state plan amendment. And then states right now have these specific disaster relief SPAs that they can use to make temporary changes to address access and coverage issues during the COVID-19 emergency. Similarly, Section 1115 waivers are a tool that states have, you know, to make a number of changes to their Medicaid program, but they have some additional authorities, and they can use those waivers right now, again, to make some temporary changes that would expire no later than 60 days after the end of the public health emergency related to COVID-19. For those of us who, you know, haven't done as much work on disasters in the past, the Section 1135 waivers may be a new coverage tool that you're not as familiar with. So these waivers are just specific to public health emergencies and disaster declarations, but the Secretary can use Section 1135 authority to waive or modify certain Medicaid, Children's Health Insurance Program, and also Medicare requirements to ensure that there's sufficient health care items and services available to meet the needs of enrollees during an emergency. So again, those waivers are really just temporary to the public health emergency. And then finally, I'll just briefly mention Section 1915C waivers are used to by many states to administer home and community-based services. We won't talk a lot about those in relation to asthma care coverage today, but those, again, there are some additional flexibilities that states have available for them to make changes to those services during the COVID-19 pandemic. So this slide compiles just a few highlights of some of the different ways states have been using these authorities that directly impact access to care, guidelines-based care for patients with asthma. This data comes from the Kaiser Family Foundation's Medicaid Emergency Authority Tracker, which is cited at the bottom of the slide. It's updated very frequently and has a lot of information about a huge range of changes as states are making in regards to their Medicaid program, not just some of the ones that I'm highlighting here today. So starting with the first bullet here, 18 states have eliminated deductibles, co-payments, co-insurance, and other cost-sharing charges during the COVID-19 pandemic in their Medicaid programs. Co-pays are a barrier to care that we track throughout all of the different categories of care we look at in the Guidelines-Based Care Coverage Project. We know that research has shown that, especially for low-income populations like the one that the Medicaid program serves, co-pays as low as $1 or $5 can really be a deterrent to patients using necessary health care services. So certainly, a barrier that we track closely through this project, and you can see that 18 states have made some changes to those policies to reduce cost sharing that could deter patients from getting care during this critical time. States have made a lot of changes specific to prescription drug coverage as a result of the COVID-19 pandemic. 28 states have waived or extended prior authorization requirements for prescription drugs. Again, this is a barrier that we track for both quick release and controller medications in the Guidelines-Based Care Coverage Project. Prior authorizations, require planned patients and providers to get prior approval from the state Medicaid plan or from the Medicaid Managed Care Plan before a medication will be covered. So states have made some changes to waive these requirements in some cases or extend them, often a prior authorization. If a patient has an approved prior authorization for a medication, it'll last for a fixed period of time, say a year, and so states have also had, extended some of these requirements to let that last a little bit longer if the patients don't have to jump through those hoops right now during this really critical time. Next, 24 states have made exceptions or changes to their preferred drug list. We're going to be talking a lot about preferred drug lists later in the presentation when we talk about one of our new issue briefs. But just again, wanted to highlight that states have been making some changes in regards to those as a result of COVID-19. We rely a lot on states' prescription drug lists when we're looking at Medicaid coverage in this project. And then finally, in this area, I wanted to highlight that 40 states have increased their maximum supply or quantity limits of certain medications. Again, quantity limits are a barrier that we track for both quick release and controller medications for asthma patients through this project. Certainly a very common barrier that we had seen over the past 4 years and continue to see this year in our data collection. So again, that's an important change that a number of states have made during this time. The last policy change I highlighted here was that all 50 states in D.C. have issued guidance to expand coverage and or access to telehealth services as related to COVID-19. We don't directly track telehealth services through the Guidelines-Based Care Project, but I just wanted to highlight this because I think telehealth is certainly an area where some of the services that we track through this project, things like self-management education, there could be some opportunities for that to be done remotely through telehealth services. And so I think that'll be a really interesting area to watch to see, how those policies move forward over the next few months and whether there may be some opportunities to extend access to certain services to patients who are in rural areas or other hard-to-reach areas related to asthma care moving forward. So I did want to talk a little bit about how we've addressed data collection for this project as a result of COVID-19. And Emma's going to do a deeper dive into our data collection process for this project in just a moment. But I did just want to highlight that we collect data from July 1st, 2019 through June 30th of 2020 was the period that we were looking at for this year's data. And so a number of the types of changes like those on these slides that are temporary, just went into, effect for the last few months of the period that we were looking at for the data this year. And ultimately, at least right now, most of these policies are temporary. And so, when we were looking at data collection, we were looking at, if a state has a copay policy for prescription medications, for example, on the books, that's their permanent policy. That will still be the policy that's reflected in the coverage data, not the temporary policies that states have put in place to address COVID-19. Certainly, if states decide to make changes to extend these policies and make them permanent, we will reflect the data to reflect that moving forward. So before I turn it over to Emma, I just wanted to briefly highlight that the Lung Association has a huge number of resources related to COVID-19, not specific to Medicaid coverage, on a huge range of issues on our website. We've certainly been at the forefront of responding to this pandemic, and so there are tons of resources on our website related to patients with asthma and managing this pandemic, about research about the signs and symptoms of COVID-19, how COVID-19 affects people with lung disease, including asthma. We have a COVID-19 blog that highlights topics in the news and other topics important to patients. We've been doing some COVID-19 virtual town halls with top health experts to discuss the effects of COVID-19 that you can listen to and register for future ones as well. We have our online support communities for patients with asthma to talk about how they're navigating the pandemic while living with a chronic lung disease. Information for our lung helpline, which is staffed with experts who can answer patients' questions, and many other resources. So if you're interested in learning more about some of the work that we're doing related to COVID-19, I encourage you to check out that page on our website. So with that, I am going to turn it over to Emma to talk a little bit about the coverage data that we're releasing today. Thanks, Emma.
Thanks, Hannah. We are in our 5th year of data collection for this project. And as Erica mentioned, we collect data for standard Medicaid programs across all 50 states, the District of Columbia, and Puerto Rico. We look at all fee-for-service and managed care plans, and then we aggregate the data at the state level. We start off by reviewing publicly available documents, which includes member handbooks, fee schedules, formularies, provider manuals, provider handbooks, anything else that is available online. After that, we work with our state Medicaid contacts to have the data confirmed, as well as any gaps that any information that we might not have been able to find online, to have those gaps filled in. Looks like we have gotten to the wrong slide. So we track 7 different components of coverage. We track both quick release and controller medications. When we are assessing coverage of medications, we are brand generic neutral, so we consider a medication covered if at least one type is covered. We track coverage of 3 different medical devices, which are nebulizers, valve holding chambers, and peak flow meters. We also track allergy testing, allergen immunotherapy, home visits and interventions for patients with asthma, as well as self-management education. We also recognize that just because a treatment is covered by a Medicaid program does not necessarily mean that patients can easily access it, so we also track these 9 barriers to care. So as Hannah mentioned, copays can create barriers to care, particularly in the Medicaid population. Prior authorization can often lead patients to delay or forego treatment altogether. Sometimes there's additional eligibility criteria for treatments, which might mean that a patient must have had an asthma-related hospitalization in order to receive a treatment. Step therapy, which is when a patient must try and fail certain medications before actually receiving the necessary and appropriate medication. We've heard from our partners that quantity limits provide a pretty significant barrier, particularly for children who spend a significant amount of time in different locations, and a child with asthma might need to have an inhaler in their home and also in their school, or if they spend a lot of time at a child care or with a grandparent, then if they can only have one inhaler at a time, it becomes a challenge to make sure that a child always remembers their medication. So that's the way in which quantity limits can be a barrier to coverage. So on our website, we have a number of state-specific resources, and as I mentioned earlier, we aggregate the data at the state level, so we have state-level summaries. Here is a photo of our database where you can click on the state or use a drop-down menu to see the data for your state. We have top-level state coverage summaries, and you can download a PDF that summarizes coverage in each state. And for example, you can see in this photo that on our page we have the summary that has the treatments and then what barriers exist in a given state. And now I'm going to talk a little bit about what we saw in this round of data collection. So we track coverage of 4 quick relief medications. And here most states are the light orchid color, which means that all 4 quick relief medications are covered, but there are barriers to accessing care, such as copay, prior auth, or any others that may be applicable to prescription drugs. And the blue states reflect where coverage might vary across plan, or there might be only coverage of some of the quick relief medications, but not all. We also track coverage of 18 controller medications. Here, most states are blue, which means that there is some coverage, but not complete coverage across all medications and all managed care and fee-for-service plans. And it's actually the same number of states that fall into that category as last year. And here, states may have improved, but that improvement might not be captured in the map. You know, for example, a state might have gone from having 12 medications covered to 16, but they would stay blue. Or one state may have hit all 18, but another state may have taken 1 or 2 off, and so those states would balance each other out. So if you have state-specific questions, I would really encourage you to look at the state pages available on lung.org and dive into what the coverage looks like in your state. As I mentioned, we track coverage of 3 medical devices. Those are the nebulizer, the peak flow meter, and the valve holding chamber. And here we saw the majority are orchid, which means that there's coverage, but there are barriers present. And there's one barrier that we track that is specific for medical devices, and that is when the device is only covered for through the durable medical equipment benefit. And these are all devices that could be accessed at a pharmacy. And so when they're only covered through the DME benefit, then patients might need to go to a specialty provider to get their equipment, which then, that is not the provider where they can get their prescription drugs, and it just creates like another step, and it makes it that much harder for patients to access the proper care. When we look at allergy testing, we look at both skin and in vitro allergy testing. And here we found this year that 7 states cover both types of allergy testing with no barriers to care, which is really great. Most states have coverage, but with barriers present. And again, that's pretty similar to what we found last year. The map for allergen immunotherapy looks all very similar. We found that 6 states cover immunotherapy with no barriers, but again, the majority of states have coverage, but there are barriers present. When we look at asthma home visits and interventions, we're looking for a specific asthma home visit. We're not just looking for home health care. So we look for 3 specific components in the home visit and intervention. Those are education, assessment, and intervention. So an asthma home visit should address the home environment for potential asthma triggers, which could be mold, pets, dust mites, pests, and then the visit should help the patient mitigate those triggers, as well as provide some education for the individual on proper use of medications or other asthma management strategies. And this year we found that 1 state covers home visits for asthma without barriers, 4 cover home visits that have barriers present, and then 13 states have coverage varying among plans. And the majority of states here have no coverage or the coverage is not available. So this is definitely a place for potential improvement in some states. Next, we look at self-management education. And when we're looking at self-management education, we are looking for specific billable codes on Medicaid fee schedules. And we're looking for billable codes for education that teaches patients with asthma and maybe also their parents of their children to learn to use prescribed asthma control medications and equipment properly, to recognize early symptoms of an asthma episode and respond appropriately, as well as to mitigate asthma triggers in the home and other environments, which might be work or school. And again, we're looking for specific billable codes on fee schedules, and we do not count disease management programs as self-management education for this project. And this year we found that 6 states cover self-management education with no barriers, 14 states cover but have barriers present, and the majority of states have coverage varying. So some key takeaways from this round of data collection. The overall numbers on the maps are similar year to year, but there are often changes to which states fall into which categories. As I mentioned earlier, sometimes individual state improvement is not necessarily reflected in the nationwide numbers. So to assess coverage in your state and really dig into what the coverage landscape looks like in the Medicaid program in your state, I would again encourage you to visit the online database where there's lots of state-specific information. Every round of data collection, we also find that transparency can be a bit of a challenge. Often all of this information is not readily available in public documents, which is a challenge for us in collecting it, but also could be an additional challenge for patients trying to navigate their care or pick a plan when they're enrolling for Medicaid. And so that's something that we would encourage Medicaid offices to work on improving transparency. And then we had an additional challenge with that, as many state Medicaid programs were responding to COVID-19, and they reallocated a lot of staff and resources in some cases, and so we were not able to, some states were not able to work with us to confirm data this year, which is very understandable given the challenges, but many still were able to help us answer some questions and review and confirm our data. And as Hannah mentioned earlier, a number of states have removed barriers temporarily due to the public health emergency. We did not count those because those are only temporary policies. We looked at the permanent policies when in regards to copays or prior authorization or any other barriers. And we found this year, as we found in previous years, that barriers to care are still a significant issue for Medicaid patients with asthma. The temporary removal of certain barriers, such as prior authorization or copay or step therapy, could create a window for stakeholders to work with their Medicaid office on extending, the removal of those barriers in the long term or making them permanent. It could be a chance to show to your Medicaid office how beneficial that is for patients. And with that, I will turn it back over to Hannah.
Thanks, Emma. And just a reminder, I already see some questions coming in, which is great. But the questions about anything Emma just covered, some of the earlier information, feel free to start chatting those questions into the chat box while I'm going through the next session of our presentation, where we'll turn over to the Q&A in a few more minutes. So, in addition to releasing our coverage data every year as part of this project, we've also released a number of issue briefs and other resources that really can help stakeholders who might not be as familiar with Medicaid coverage and some of the often complicated policies and benefits that control coverage for patients with asthma, to really help you understand those benefits better, understand Medicaid coverage better, and hopefully make sure that that's not a barrier for stakeholders to work with their Medicaid programs to work on improvements in guidelines-based care. So I'm going to talk about 2 resources that we're releasing today that will hopefully help stakeholders, work with Medicaid programs in the areas of medication coverage and device coverage with a little bit more ease if your state has issues to address in those areas in terms of improving access to guidelines-based care. And then I'll just go over generally some of our broader resources for this project and make sure you know where to look if you want to do a deeper dive on some of these issues. So the first issue brief that we're releasing today is on common formularies in Medicaid and implications for asthma care coverage. So if you haven't heard of a common formulary before, it's a state-prescribed list of preferred medications that are available to all Medicaid beneficiaries in the state, regardless of payer, whether that's the state Medicaid fee-for-service program or if the state has a managed care plans in their state for Medicaid, one of the managed care plans in their state. So this issue brief goes through what common formularies are, why states might consider them, and what some of the implications of common formularies are for asthma care coverage in Medicaid. if a state is moving towards a common formulary, it's likely not, in response to trying to improve coverage or address some of the gaps specifically in average asthma coverage that we talk about through this project. It's more often, about controlling medication costs for the Medicaid program and using them as a tool to help with that. But it really can have very important implications for Medicaid coverage of guidelines-based care. And so that's why we really want to help people understand the kind of spectrum of formularies that states have in their Medicaid programs and how those affect asthma coverage. So on the kind of the far end of the spectrum are states that have no common formulary. And so if you have a state that uses Medicaid managed care to help administer their asthma program, their Medicaid program, they could have state, beneficiaries involved in 1 or 2 or even 10 or 15 or 20 different managed care plans in the state. And so if the state doesn't have a common formulary, they will often have a preferred drug list for the state fee-for-service program, and then each of the individual plans will have their own preferred drug list. And so the medications that are covered without prior authorization and other barriers can differ from plan to plan to plan in that state. And obviously that can be, that's a lot of documents for patients and providers to review, and can certainly create challenges if stakeholders are trying to work to improve coverage in a state with 10 or 15 managed care plans. Working, having to work individually with all of those plans can certainly seem like a bigger lift. The next kind of step that I'll talk about is a limited common formulary. And in these cases, states will often create this common formulary where, the same medications have to be covered with the same, prior authorization and other requirements. For a smaller subset of drugs, specialty medications, often higher cost medications. So most of the asthma medications that are included in the current NAEPP guidelines that we track through this project are not often in that kind of specialty tier group. And so if a state has a limited common formulary, most of the time, the vast majority of asthma medications are still left to the individual managed care plans to manage, and so stakeholders still have to interact primarily with all the different MCOs to address issues related to coverage. So the next step we have here is the comprehensive common formulary. And in that case, this is what I was talking about earlier. All of the states, the plans and the state Medicaid program have to use one single preferred drug list, and regardless of the plan that you're covered in, those are the medications that are available to the beneficiary without prior authorization, and they have, the standardized requirements in terms of prior authorization, step therapy, some of the other barriers that we track. So this can, as I mentioned earlier, provide consistency for providers and patients, not having to figure out, what the different coverage requirements are for each managed care plan. In this case, stakeholders who are looking to work on coverage issues will often need to work primarily with the state Medicaid program, who's usually the one that is deciding what medications will be on that list and how they will be covered. But there still is an opportunity to work with the Medicaid managed care plans on efforts to improve access and adherence to asthma medications, since the Medicaid managed care plans still are implementing this coverage, even if they have to all use the same common formulary. And so the fourth option I'll just briefly mention, kind of at the other end of the spectrum, is a carve-out strategy. And in these cases, there's I think about 4 states that have this right now. The prescription drug coverage is carved out of the Medicaid managed care plan's contracts. And so all of the state continues to manage prescription drug coverage itself directly. And so in this situation, all of the decisions around coverage, any efforts to improve coverage really need to be conversations with the state Medicaid program, as the Medicaid managed care plans have much less discretion over what isn't covered. So if states have taken one of these last 2 approaches, having a common formulary or carving out prescription drug coverage, some of the possible advantages would be that there's consistency for patients, especially if they're changing, from one managed care plan to another Medicaid managed care plan. Their prescription drug coverage and their asthma medication shouldn't have to change. We also hear a lot that these common formularies are easier for asthma providers and for pharmacists. who only have to, follow changes to one preferred drug list rather than, again, 5, 10, 15, or 20 for each of the different managed care plans in their state. But on the other side, and again, the issue brief goes into some of these pros and cons in much more depth, but on the other side, I just want to caution that a common formulary doesn't necessarily mean that a state will have comprehensive coverage of all of the asthma medications that we track through this project. A state can have a common formulary that only covers 8 or 10 or 12 of the 18 controller medications that we track without barriers to care, without prior authorization, those kinds of barriers. And so, if a state is moving to a common formulary, I think there are real opportunities for the state asthma program and for other stakeholders to try and be involved in that process and make sure that if the state is going to be setting, one standard for coverage across all of the different Medicaid plans, that is a standard that really ensures that patients with asthma have access to all of the medications that are recommended by the NAEPP guidelines. An example of a state that we highlight in this issue brief that has just made this change to a common formulary is Ohio, which implemented a common formulary on January 1st. And the issue brief highlights a survey that the Department of Health asthma program did in Ohio this spring, asking health plan partners about the impact of the change. And the Medicaid managed care plans reported some challenges with specific medication transitions for beneficiaries as they were implementing the new common formulary, as well as some issues with differences in age limits and restrictions for the medications and what was on the common formulary and what they had covered previously. But they also reported that in this case, the change did result in some additional medications being covered, a real appreciation from prescribers about the more consistent coverage, as I talked a little bit about earlier, and a willingness of the Ohio Department of Medicaid to be flexible. So again, I think this really just highlights that if this is as a number of states consider moving to some of the, a common formulary or something similar, there really are opportunities for the asthma community to be involved in that process and make sure that guidelines-based care for asthma patients is considered as these documents are being developed. So again, if you're interested in learning more, if you have key gaps in your state in terms of Medicaid coverage and interested in learning more about this topic and how it might impact Medicaid coverage and medication coverage in your state, definitely encourage you to check out this issue brief. The second issue brief that we are releasing today is on durable medical equipment for patients with asthma. And so Emma talked a little bit earlier about the DME benefit, which we track in this project, again, because if patients have to go to a specialty DME provider rather than getting a device that they need to manage their asthma directly from a pharmacy or provider or the health plan, that can create an additional, barrier to care that makes it harder for patients to get access to the devices that they need. So this issue brief kind of takes a look at the durable medical equipment benefit, which again is a mandatory benefit category in the Medicaid program that includes medical supplies, equipment, and appliances for use in the home or other settings. How it looks at how this benefit differs between fee-for-service and managed care plans, some of the issues patients may face trying to get coverage of a device through the DME benefit and how they can appeal it if the device that they need is not covered. And then walks through some of the lung association's data on how often asthma devices are covered as DME. Over half of state Medicaid programs cover all 3 of these devices as DME in their Medicaid programs. And it also looks at some of the other barriers to care that the patients face when accessing their devices. Again, Emma mentioned some of these earlier, but things like quantity limits can be an issue. Co-pays, prior authorization are all barriers that patients can face and can have make it harder for them to access the devices that they need. Another state example that's highlighted in the issue brief, and I'll just highlight here, is that Michigan's Medicaid program changed its policy to allow all fee-for-service and managed care enrollees to access up to 4 spacers or valved Holden chambers per year at a pharmacy without prior authorization. And just, a couple of things I'll highlight about that policy, allowing patients to access these devices directly at a pharmacy rather than through the DME, especially DME supplier, removes a barrier to care. Obviously, without prior authorization, that removes another barrier to care. And I think it's really important that patients have the quantity limits also be addressed as well, making sure that patients can have up to 4 valve holding chambers, again, for issues with children and getting access to the devices that they need to manage their asthma, as Emma mentioned earlier. Making sure that, patients only don't have access to 1 or 2 of these devices and have the tools that they need to manage their asthma can be really important. So really, again, if you see gaps in device coverage in your state and you're interested in learning more about how these devices are covered and some of the Medicaid terminology that you might need to learn to help navigate these coverage issues, I encourage you to check out that issue brief as well. So finally, before we move over to Q&A, I will just highlight lung.org/asthma-care-coverage is the hub to go to for all of our asthma resources related to this project. We have a number of webcasts archived on that website, and we will, in a few days, post today's as well if you or other colleagues are interested in listening to it. These webcasts go through our previous coverage data releases and also other educational resources on issues related to Medicaid coverage of guidelines-based care that we've released in the past. The website also has the 7 coverage maps that Emma went through that give the national snapshot of asthma coverage across the different categories of care that we track. And then again, that's where you can find that state-specific database. That's really, I think, for a number of the stakeholders on the call today, that's where you'll find the most valuable information about what is covered in your state, what barriers exist, and really take a closer look at the state-specific information. I will also just mention that if you are an asthma program or an asthma coalition in a state that is interested in doing a deeper dive into your Medicaid coverage, please always feel free to reach out. I'll have our contact information on the next slide, but we're always happy to do more targeted calls and presentations to talk about that information with you. And then finally, the website has a number of previous issue briefs that we've released on asthma care coverage, including the 2 new ones that I talked about today. So with that, I think I am going to turn it back to Erica, and we can move over to questions and answers. And as well, again, asthmacare@lung.org is the best place to reach us if you have questions about this project.
Wonderful. Thank you so much, Hannah. And excited to see all the questions that have been submitted, and let's see how many that we can get to in our remaining time. So the first question that we had is, what is the difference between covered and covered without barriers when we look at our data?
I can start with that one. So covered means that all of the medications in that category are covered in that state, but they may have barriers, either that we don't have information available on barriers, or that we do see evidence of barriers like copay, prior authorization, et cetera. Covered without barriers definitively means that we were able to get information on all of the different barriers for that category of care and all of the different medications or services in that category, and we were able to see that there were no barriers existed for all of those different components.
Wonderful. This is a question about self-management education. Would it be more appropriate to call self-management education coverage physician counseling? It seems like the terms are often interchangeable and may mean many different things to different people. So is self-management education the same as physician counseling?
I will say, we have a little bit more information about how we define self-management education in our benchmark document on our website, which I encourage you to check out, and I'm happy to have a more in-depth conversation with if people have more questions about that. Generally, we do when we're looking at self-management education coverage, one of the main things we're looking at is, the type of information that's being covered in that session, not necessarily what the provider is. If it's a physician or a different, a community health worker, a different provider, isn't something that we look at when we're determining whether or not something is covered.
Here's a question from someone asking a little bit about the COVID-19 public health emergency. My state has extended coverage and removed barriers because of the federal public health emergency. Has the emergency time period been extended beyond July 31st of 2020?
I can take that one as well. I don't believe it's been extended yet, and so that's something that we're continuing to monitor pretty closely.
Wonderful. Many asthma medications are life-saving or contribute to more costly adverse outcomes, such as hospitalizations. Why would asthma medications not have broader coverage like insulin and other life-saving medications do?
Well, I think that's a great question. It's certainly something that, we think that, everyone should, we think that all of the medication use projects should have, should be covered by all Medicaid programs. I will say that in terms of some of the evidence around, the return on investment of different parts of guidelines-based care, there has been a lot of research that I think we need to do a better job of making sure people understand. And so we do, one of the research on our website is a resource on that return on investment of guidelines-based care. So if you're interested more in that topic, I encourage you to check it out.
Great. Emma, maybe this is one that you can answer. Have you found any coverage for virtual self-management education?
We do not look at telehealth in this project. And so, no, I have not found any specific information about virtual self-management education.
Okay. Emma, here's another question for you. What components of coverage seem to change the most from year to year?
It's a great question. Probably the component with the most opportunity to change from year to year is the drug coverage, because often a Medicaid program may review their formulary as frequently as 4 times a year. So those are, 4 different opportunities where coverage could change. A lot of the other coverage, adding something to a fee schedule might be a little bit more complicated as those are not reviewed as frequently.
Okay, great. Here's another question that we have come through. My state has a lot of work to do, this person wrote, in terms of coverage. Is there a component of care or even specific medications that would be most important for us to look at?
I can take that one. I think a lot of this really varies specifically on the state, and I really encourage people to really work with the Asthma Coalition and other partners in your state when you're trying to make decisions about prioritizing coverage. I think sometimes there's a tendency to see that a whole category of care isn't covered, something like home visiting, and really, primarily focus on some of those bigger ticket items, which, you may decide after, doing that assessment with the asthma stakeholders in your state makes sense. But I also think that we've found, talking with providers on the ground, that sometimes it's some of these smaller barriers that can really make the biggest difference. Emma shared the example earlier that we had heard from some asthma stakeholders in New England about how some of these quantity limits around devices and inhalers were a huge problem in helping community health workers and other providers on the ground working with children trying to control their asthma. So I really think the most important thing is to reach out to a good group of stakeholders in your community and try to make those decisions collaboratively.
And Hannah, that seems to dovetail well into a question that we received. What about strategies that are most effective in advancing coverage in the state for home visiting? And again, really recognizing that is something that there has been some good examples of progress that's been made at the state level in the last few years, but to work very closely with coalitions on that front. I don't know if you or anyone else would have any other aspects to add with regard to those strategies for improving home visiting.
Well, I think the thing that I will just highlight is that last July, we released a report that looked at some of the best practices that we found after a year of working with 4 CDC-funded asthma programs who had been doing work specifically around home visiting coverage and self-management education to improve coverage and work with their Medicaid programs in their state to improve coverage. And so we did a number of conversations with those grantees and surfaced a lot of best practices in terms of everything from what data you need going in to navigating the relationships with Medicaid, and just a lot of really great tips in that document from some really impressive state asthma programs who've done some really great work in this area. And so that issue brief is on our website at lung.org/asthma-care-coverage. So if you're interested in learning more about that, I would definitely encourage you to check out that report.
Wonderful. Let me throw this one out to Emma. How will the new NAEPP guidelines impact this project?
Thanks, Erica. So we are still waiting on the final NAEPP guidelines. I believe they're expected later this fall. And the Lung Association will be working with a number of experts to address our benchmark document and see what in the benchmark document for this project will need to be updated with the new guidelines so that we're making sure we're tracking the most up-to-date guidelines recommended asthma care coverage.
Wonderful. Here's another one for Hannah or Emma. How can I find out if my state has a common formulary?
I can take that one. So generally, if you go to your state's the web page for your state Medicaid program, you should or just search in your internet browser state name, Medicaid program, prescription drug coverage. You should be able to find the page on the website. It gives you some general information on that topic. The other thing I will say is that the Kaiser Family Foundation does an annual survey of state Medicaid programs, and they released a report earlier this year that looked at a number of things related to Medicaid prescription drug coverage. But one of the questions that they did ask was about common formularies. So they have a table. If you're having trouble finding it, feel free to send us an email. I can help you track it down. But they did looked at, as of July of last year, they have a chart that that shows which states have common formularies, which states have the carve-out prescription drug coverage, which states don't have any managed care plans, and so just have fee-for-service drug coverage. That can be a helpful tool to take a look at that. I think it's also cited in the report that we put out as well.
If we do not have a local asthma coalition, how do we determine which policy change will have the greatest impact?
I think even if you don't have a local asthma coalition, you can certainly, informally reach out to other stakeholders in your community. Again, I think, critical stakeholders like the state asthma program staff, if you have that in your community, different patient groups like the Lung Association chapter in your state, providers, both physicians, but also, community health workers or certified asthma educators and other patients who might be working directly with asthma patients. Those are the types of voices I really think that you want to have in the conversation, even if you don't have a formal coalition that brings those groups together on a regular basis. And who knows, maybe you can that can be the impetus for starting a more regular conversation between those stakeholders in your state.
Back to common formulary questions. Is there a state that's done a particularly good job transitioning to a common formula and common formulary, and were asthma stakeholders engaged in that process?
So one of the things we found when we were doing the common formulary issue brief was that there wasn't a ton of information available kind of evaluating common formularies in some of these transitions. I mentioned briefly in the presentation, the state of Ohio did, their asthma program was involved in that process and did do a survey looking at the impact. So there's more details about that in our issue brief. I encourage you to check that out.
Okay. It looks like we've got time for one or two more questions. Let me just ask real quickly, Emma, how often do these data change, and what components of coverage change the most frequently?
So we do review all of this annually. So every year we go through and look at all the different components across all 50 states and all plans. Probably where there's the most variation is in the medication space. They may, a state may swap out drugs as they review the formulary, or this year we saw a lot of temporary changes made to barriers. But even in normal years, sometimes step therapy might be added for a drug and then taken off the next year, or really the changes around. Since the formulary is reviewed four times usually a year, there's a lot of potential for it to be updated frequently.
Okay, great. And this seems like a fitting last question, even if it means that we're running out of time and won't be able to get to all of them, but this is a good one to end on. Would someone at the Lung Association be able to speak to my coalition or be willing to work with us to help develop a strategy to improve coverage in my state?
Yes. Email us at asthmacare@lung.org, and we're always happy to, especially now as we're doing a lot more, webcasts and, virtual meetings, regardless of where you are around the country, we're always happy to call into a meeting or do a more state-specific presentation for an asthma coalition or different groups. We've done those in a number of different states, and are happy to do that for you. So please just shoot us an email, and we'll work to set something up.
Erica, this is Pam. I wanted to ask one last question for Hannah and Emma about once you're collecting your data, how you are verifying and validating the information about the coverage.
Sure. So every year we reach out to state Medicaid programs. We have contacts in all 50 states and DC and Puerto Rico's Medicaid program, and give them an opportunity to review the coverage data. Sometimes they review it themselves, and sometimes they also will disseminate it to the individual managed care plans to have them review the data. And then once we get that information back from them, we ask them any kind of follow-up questions that we have. And then we aggregate all of that information at the state level. So we don't release the plan-specific data, but we aggregate all of that information that we got back from them to get to the point and the information that we released on our website.
Wonderful. It's definitely a very thorough process. Well, with that, I want to thank everyone for taking the time to join us today, for all of your thoughtful questions. And I'm sorry that we couldn't answer all of them. I want to say a special thank you to Pam Collins of CDC, Hannah Green, and Emma Will from the Lung Association for your time and expertise this afternoon. And again, please email us at asthmacare@lung.org or go to the website at lung.org/asthma-care-coverage as well. And we also will have this recording available within about 24 hours on that landing page. So thanks, everyone, and have a good rest of your day.
Thank you again for participating. This concludes today's conference. You may now disconnect. Presenters, please.